For those of you who don't know me, my name is Veltman and I work in Veltman. I'm a family doc, and just by pure happenstance, I happen to have acquired some expertise in this area. At this time, I see about 120 people, about 60 of whom are from the Peterborough area. But I do see people from as far as Guelph and Timmins, and Kingston and Ottawa as well. As family docs and MPs, I think we usually think of a few things when we think of whether an issue is important. Like, is it common? Is it something that we'll see? Is it serious, associated with morbidity and mortality? And can I do something about it? With respect to prevalence, while there's wildly varying estimates from lows of 1 in 30,000 to more recent data suggesting maybe 1 in 200, it's clear the numbers are rising. In my own practice, which is purely from retired physicians here, I have 6 people. That's a rate of 1 in 275. And many of you have been kind enough to send me referrals, and I would have to guess that most people have 1 or 2 or 6 people in your practice who need your care. In terms of morbidity and mortality, much of this is associated with discrimination and impacts on social determinants. And in healthcare, the issue is access to care. There's significant morbidity and mortality issues associated with lack of access. Canada, the U.S., and Great Britain all report rates of suicidal ideation in the 40% range, with the highest risk being in the interval between self-identification as trans and the time to appropriate care. And as for whether we can do something about it, I think it's well within our scope to care for these folks. And clinics such as the CMHA clinic actively encourages MPs and docs to do their own assessments and management, and there's many guidelines and supports to help with this. I also think that it's a natural fit for us as primary care, and when our work involves supporting people in transitions of all kinds through their life. Locally, we're fortunate to be supported by the Trillium-funded grant, which is headed by the CMHA in partnership with other organizations, including the Peterborough Network FHT, which supports initiatives like Gender Journeys and educational initiatives such as this one. Thank you for the opportunity to introduce this important topic.
So thank you very much to Gender Journeys group who invited me here. And part of the ask was to also talk about hormones, and I said, well, the psychiatrists don't prescribe hormones, so can I bring my friend Dr. Karis Mazzarella to speak about that issue? So we're going to try to split our time pretty evenly as much as we can. Just to let everyone know, we are trying to videotape and audio record this as well. This is because we are actually trying to develop some curriculum for use in healthcare education programs, so we're hoping that some of this can be used for that purpose. So if people are uncomfortable to ask questions in that environment, barriers. And there has been a medicalization and a pathologization historically of transgender individuals. And so people have experienced judgment, patronizing, humiliating treatment. And so, of course, that's going to be a barrier to any future care. Even as simple as intake forms and office environments are not, for the most part, trans-inclusive. So that's going to be a barrier to care as well. And then just coverage issues in terms of some of the things that people want to access are not covered. Or certain parts are covered and other parts are not, and we can get into that a little bit later. I think Dr. Mazzarella will also get into that. And there's just no wait list for everything, so these are all barriers to good care. In terms of standards of care, and again, Dr. Mazzarella will go through some of the hormone treatments a bit more, but there are some really great standards of care. These are just some of them. There's also the Shoreboard Health guidelines. There's some stuff out of Vancouver Coastal Health, which is excellent. So there are some great standards of care that are available to everyone. Dr. Mazzarella will go through this a little bit more, but I'm just going to briefly touch on gender-affirming surgeries. That surgery is an effective intervention for patients, for individuals who have gender dysphoria. And people always worry about, what if we make a mistake? What if we, approve, quote unquote, someone for surgery, and then they regret it? the rate of regret is so, so low that it's just something that I don't worry about, truthfully, okay? And I do work at CMHA Gender Clinic, which we can get into, it's controversial, but I work there because it's not like it used to be, okay? And I would never have worked in the environment that it used to be, okay? But it's always, how do we get people to yes now? That's the philosophy of CMH's clinic now. So even if someone's not quite ready for whatever reason, it's how do we get them to, yes, you're approved, we can go ahead, okay? And that's the philosophy of the clinic now. And it was, it still is a gatekeeper. It was very much more so a gatekeeper in the past. We do believe that people do better after these surgeries that they're asking for, and that the rates of regret are so low that it's just not something that we really worry about anymore. It was something we really worried about in the past. Coverage is province to province, so it depends on where you live. Provincially here in Canada, how many of these surgeries and what is covered and what is not. So we'll go through that a little bit more at the 9 o'clock lecture. But these are possible surgeries, not all of which, in fact, most of which are not covered by OHIP. Very quickly, there are different ways of asking the questions with respect to gender, and you have to find a way that sort of works for you that's respectful, okay? But these are some of the options that you can ask people, but you have to keep in mind that you have to know why you're asking the questions and whether it's really important for the issue at hand, okay? So if, for example, somebody's going into the emerge with an injured finger, okay? Dr. Mazzarella has a broken finger. So if someone is coming into the emerge for something like that, do you really need to know what their gender history is and whether they've had any genital surgeries? Does it matter? It doesn't matter, right? So, as you're sort of trying to figure out what questions would you feel comfortable asking somebody about their gender or transgender status, you have to think, why am I asking these questions and is it appropriate in this context? Some other possible questions that you might want to ask. And a lot of the questions are about people's self-identity and about if they do identify as transgender, their coming out process and how many people are they out to, what was people's reaction. It's more assessing that than somebody's legitimacy as a transgender individual, right? That's not really people's role to decide that. This is from Asking the Right Questions 2, which is a document that's available for free on the internet. It's produced by CAMH. And this is some suggestions about how you can actually put this on your forms. Okay? So intake forms to whatever service usually have male, female as options for identifying someone's gender. You usually don't have any other options. So these are some other options that you can put on your forms. And it's a relatively easy thing to make your practice, your health center or wherever you're working, a more trans-positive environment. I don't know that I love this first question. It is from Asking the Right Questions too. At what age did you first identify as transgender or genderqueer or lesbian or gay or bi or whatever? So they do have that listed as a question. It's sort of like, well, at what age did you first identify as straight or as cisgender? Like it's sort of, to me, a silly question, but it is one of the questions in Asking the Right Questions too. The rest of them I do like. But again, you have to find what works for you and in the right context with it. I started my practice in 2008, having graduated from the psychiatry residency program at McMaster, where there was no LGBTQ education at all, not 1 minute of lecture time on LGBTQ issues during my residency. And there was nobody doing this work in Hamilton at the time. And when I graduated and wanted to start an LGBTQ clinic in collaboration with the LGBTQ Community Wellness Center of Hamilton, or the WELL for short. I was told by my hospital, which is a Catholic organization, St. Joseph's Hospital, I was told by senior administrators what would the nuns think. And And, if you want to do that in collaboration with the community, you can do that on your own time, quietly. That's what I was told initially. I say that very freely in environments now because St. Joe's has really changed their viewpoint on this, and now I actually see patients at my office at St. Joe's for a variety of reasons that we can get into later. But St. Joe's does support this work now. And Karis Mazzarella can also speak to her experience at St. Joe's and as head of, what was the actual position? President of the medical staff. So Karis was president of our medical staff association for a year, right? So anyways, things have changed in a short period of time, and now we do have LGBTQ curriculum in the residency program and in the medical school environment where we didn't have that even a few short years ago. So, just to start there. So, no conflicts of interest to be clear. I don't know if you guys do this at Grand Rounds, but... So in terms of objectives, so we're going to have to go pretty quickly through this, and I know some of you are staying for the other talk at 9 a.m., and it's going to be a little bit different from me. I think it's going to be fairly the same from Dr. Mazzarella, but she's going to be open to a lot of your questions about hormones during that talk. So for this particular piece of it, we're going to be going through terminology very quickly. I just want to make sure that everybody is kind of at the same place in terms of understanding the basic terminology. Otherwise, it's difficult to move on from there. Gain knowledge about some of the specific healthcare needs and the healthcare needs of transgender individuals. So I am a psychiatrist, so I am going to go from that perspective, accessing both mental health care and general health care for this population. And a little bit of knowledge about how to reduce some of the healthcare barriers for this population. We don't have time to be interactive, so I'm just going to give you the answers. Okay. So sexual orientation versus gender identity, believe it or not, is something that people still struggle with understanding the difference. So I kind of try to do it in a fun way that people can remember. So for me, I teach it in two ways. So sexual orientation is about who you love, and gender identity is about who you are. So that's one way to kind of remember the difference. The other way to remember the difference is a little bit more bold, I guess, and that is sexual orientation is between the legs, gender identity is between the ears. So hopefully you'll remember one of those ways and never make a mistake. So an ally is someone who is not, so in this context of LGBTQ issues, an ally is someone who's not necessarily part of the community, but who really believes in equity and social justice for LGBTQ individuals. So even if you are not identifying yourself as LGBTQ, you can be an ally. So just very quickly to go through a couple of different terms here. So the difference between transgender and transsexual is sometimes confusing for people. And it is really about self-identification. So someone, like you might think, oh, they're transgender, but they may actually label themselves a different way. Okay? So you do have to go with how your own individual client is labeling themselves and what terminology they use to describe themselves. But transgender is an umbrella term that encompasses many different possibilities of identification. So people may identify as transgender who are transsexual, two-spirit, maybe intersex, maybe genderqueer, and then all of those folks might identify as transgender. Transsexual is usually a term that's used for people who are actually pursuing or who have pursued hormones and or surgeries to kind of align their bodies to the gender that they perceive themselves to be. Okay? But again, not everyone who has pursued hormones or surgeries might identify that way. They may prefer a different term, like transgender. Two-spirit are people who identify as two-spirit are usually of Native background, First Nations background, and the idea is that they perceive themselves to have both feminine and masculine spirit within within their one body. Transgender, but they may also be lesbian or gay or bisexual. Okay, so just because they identify as two-spirit doesn't mean necessarily that they also identify as transgender in any way. Intersex, I put in here even though it's a different concept, but it does sometimes get confused, so that's why I put it in here. So intersex individuals are individuals who have a disorder of sexual development, we call it, that means that perhaps their chromosomes don't quite match with their identities, or they may have a hormonal issue. So these are, again, disorders of sexual development where perhaps genitalia are not clear or the genitalia don't match with the chromosomes, etc. Genderqueer is sort of a politicized term. So there are some individuals who are transgender or fall within the transgender spectrum who prefer the term genderqueer. It's usually younger people and more politicized people. Transition. So transition can be different things. So sometimes people, especially medical professionals, sort of believe that transition is only, if you're going from male to female with hormones and surgery and everything, and that's transition, or the opposite way, female to male. Transition can be a lot of things. It's not necessarily that. Okay. So transition can be a social transition with or without hormones and surgeries. And it's not so black and white always for people to go from male to female or female to male. Transition can be to something in between. Passing, so it's sort of a little bit of a slang term, but I'm not sure that there's a better term for it. But someone who is transgender, who quote unquote passes as the gender that they're wanting to be perceived as. For all intents and purposes, as they're living their lives in the community, they're perceived by others as female, they are passing. Okay? I don't like the term, but I don't know that there's a better one. Please let me know afterwards if there is a better one. Stealth is a term that some transgender individuals use when basically they have transitioned to the gender that they perceive themselves to be, and they are passing all the time and not letting anyone know that they have this history of being transgender. Okay, so they go stealth, meaning they live their lives as the gender that they've become, that they always perceive themselves to be. Transphobia is sort of a corollary to homophobia, okay? But it's discrimination, fear from society, misunderstanding of trans individuals. Very quickly, I get referrals sometimes that say female transsexual. Please see for this mental health reason. And I don't really know what that means when I get those referrals, so I don't really understand what they're trying to say, like, is this person M to F, F to M, I don't know, right? So these are kind of more appropriate ways of doing your referrals, if you're going to be doing a referral. So the M to F can be spelled in those ways, or you can kind of identify that person as a trans woman. Someone who's gone from male to female or is wanting to go from male to female. Same with the trans man. Cisgender is a term that some people are not familiar with. If you're not transgender, you're cisgender. Okay? So I was born female, I identify as female, I'm cisgender. Some people call it, and it's a bugaboo of mine, they call it gender reassignment surgery. You're not reassigning anyone's gender when you're doing these kinds of surgeries, okay? Gender's in the brain, remember, okay? So you are reassigning genitals, okay? Or reconstructing genitals to fit with the gender that people perceive themselves to be, okay? Or you're affirming or confirming somebody's gender when you're doing those kinds of surgeries. So this is the preferred terminology for gender reassignment surgery. You're not ever reassigning someone's gender by performing any kind of surgery. Does that make sense? All right, inappropriate terms. inappropriate terms, okay? I've seen all of these in consult notes, believe it or not. I've seen colleagues and heard colleagues use these terms. Please don't. Okay? The terms we went through are the better ones to use. Just quickly, and Dr. Lokanathan went through this a little bit in what she said as kind of an introduction to our talks. Statistics vary widely. Epidemiology on this issue varies widely, depending on how the study is done and where the study is done. So previous studies have shown really low rates of transgender individuals in the community, but they were really looking at people who were seeking genital reassignment surgery. And not everybody does seek genital reassignment surgery for a variety of reasons. And so it's not a great way of estimating transgender individuals in the community. So better ways, more recent ways, have shown basically the 1 in 200 kind of statistic that Dr. Lokanathan was talking about. So again, 0.5% of the population, 1 in 200, that's probably the most accurate estimate we have right now. So, gender dysphoria in the DSM-5. So before, when we had DSM-4, it was called gender identity disorder, and there was a lot of lobbying that was going on even within the psychiatric community, and certainly CMHA, Canadian Professional Association for Transgender Health, and WPATH, the World Professional Association for Transgender Health. We were all lobbying to get rid of gender identity disorder from the DSM. So I think everyone knows what DSM is, Diagnostic and Statistical Manual. It's said to be the Bible of psychiatry. I hate that terminology, but it's kind of true. There was some lobbying going on to completely remove it. Okay. Unfortunately, that's not what happened, but it was renamed. It was renamed as gender dysphoria. Okay. So DSM-5 contains pretty much very similar diagnostic criteria for gender dysphoria as it did for gender identity disorder, but the name has changed. To hopefully a less stigmatizing name, but there's still debate going on within the psychiatric community and certainly within trans activist communities about does it belong in the DSM. My personal opinion, even as a psychiatrist, is it doesn't belong in the DSM. It is not pathology. It is not a psychiatric illness, but it's there. I guess one of the questions is if it's not under psychiatry's umbrella, whose umbrella would it be under? My argument is it should be under endocrinology or family medicine, but endocrinologists and family docs have not all taken up the cause yet. Some people have, but not everyone. Okay, so depathologizing transgender identity. This is a quote from the American Psychological Association, talking about why being transgender is not a pathology and should not be really considered a psychological illness. I think everyone can read this, but I'll read it quickly. A psychological condition is considered a mental illness only if it causes distress or disability. Many transgender people do not experience their transgender feelings and traits to be distressing or disabling, which implies that being transgender does not constitute a mental disorder per se. It's a pretty strong statement from APA. From the WPATH, there's been a couple of statements that really speak to this as well. It's a matter of diversity and not a matter of pathology. So that's the second one from the Standards of Care from WPATH. I won't read the other one. Again, from the Standards of Care, talking about treatment aimed at changing somebody's perceived or gender identity and their gender expression is unethical. Okay, doesn't work. And it's unethical. Okay. So some special considerations in terms of transgender mental health. There is an increased vulnerability within this population for a variety of mental health issues, including depression and suicidal ideation. But you have to think about why, right? So again, it's not that the transgender identity itself is the cause of the issue. It's not that that is pathological and that's the reason why. The reason is our society and all of the increased burden that people have as transgender individuals because of discrimination, transphobia, cisgenderism. Okay, and also how we as a medical profession have been treating transgender individuals even to this point. It doesn't help that many of us in the healthcare community have a history of pathologizing transgender identity, so that doesn't help either. And there are just some systemic issues because of the minority status. So most of the studies, when we look at transgender individuals, have been done on trans women. I'm not really sure why, because we do know that trans men exist in equal numbers, or almost equal numbers, to trans women, and yet most of the studies have been done on trans women. So, I mean, I guess the corollary to that is that most studies on everything have been done on men. So I don't really understand why. But anyways, when we look at most of the studies, they do show high rates of depression. Up to 62% of trans women report having been depressed at some point in their life. Very high rates of substance abuse as well in some of these studies. Now we have a more local study, TransPulse, so you can see that very well, but that's from TransPulse, which was an Ontario-wide study of trans-identified individuals, and this was more equal in terms of numbers of trans men and trans women. And unfortunately, it did show very high rates of suicidal ideation in trans individuals here in Ontario. So even in the past year, 32% of people in the study identified that they seriously considered suicide in the past year. If you look at lifetime risk in the same population, 77% had seriously considered suicide. So very high rates, even of attempted suicide, so 10% in the past year, 43% lifetime risk. So these are some pretty serious mental health issues that we're dealing with here in this population. But again, I just want to stress this as much as I possibly can. It's not about the transgender identity, it's about people's experience in this society that is transphobic. That's what's causing this. So in terms of barriers to accessing health services for transgender individuals, there's several barriers, and probably more than on this list, and maybe we can get into it more when we're in the workshop for some of you who are staying. There's a lack of knowledge and discomfort of healthcare providers, so it's great that all of you guys are here today. But there's lots of healthcare providers who don't want to talk about this topic, who have never had any education on this topic and don't want it, avoid it, send people to see other people, or just don't talk to patients at all about these issues. So unfortunately, we're still dealing with that kind of discrimination within the healthcare field. There's not enough people doing the work. So I know here there's a few people doing the work, but they're probably overwhelmed, right? We're overwhelmed in Hamilton and in St. Catharines, where Dr. Mazzarella and I work. I have a year-long wait list right now. You have a 9-month wait list right now. So, there's not enough people doing the work. There's sometimes people who identify as transgender have had extensive negative experiences with the healthcare system. And either they themselves have had that, or they have friends who identify as transgender who have had these negative experiences, and that's a barrier to care because people assume that if other people had negative experiences, I'm going to have a negative experience, or I've had these negative experiences, it's going to be the same if I go to see this new doctor. So those are all healthcare barriers. And there has been a medicalization and a pathologization historically of transgender individuals. And so people have experienced judgment, patronizing, humiliating treatment. And so, of course, that's going to be a barrier to any future care. Even as simple as intake forms and office environments are not, for the most part, trans-inclusive. So that's going to be a barrier to care as well. And then just coverage issues in terms of some of the things that people want to access are not covered, or certain parts are covered and other parts are not, and we can get into that a little bit later. I think Dr. Mazzarella will also get into that. And there's just no wait lists for everything, so these are all barriers to good care. In terms of standards of care, and again, Dr. Mazzarella will go through some of the hormone treatments a bit more, but there are some really great standards of care. These are just some of them. There's also the Shipboard Health guidelines. There's some stuff out of Vancouver Coastal Health, which is excellent. So there are some great standards of care that are available to everyone. Dr. Mazzarella will go through this a little bit more, but I'm just going to briefly touch on gender-affirming surgeries. That surgery is an effective intervention for patients, for individuals who have gender dysphoria. And people always worry about, what if we make a mistake? What if we, approve, quote unquote, someone for surgery, and then they regret it. The rate of regret is so low that it's just something that I don't worry about, truthfully, okay? And I do work at CMHA Gender Clinic, which we can get into, it's controversial, but I work there because it's not like it used to be, okay? And I would never have worked in the environment that it used to be, okay? But it's always, how do we get people to yes, no? That's the philosophy of CMH's clinic now. So even if someone's not quite ready for whatever reason, it's how do we get them to, yes, you're approved, we can go ahead, okay? And that's the philosophy of the clinic now. And it was, it still is a gatekeeper. It was very much more so a gatekeeper in the past. We do believe that people do better after these surgeries that they're asking for. And that the rates of regret are so low that it's just not something that we really worry about anymore. It was something we really worried about in the past. Coverage is province to province, so it depends on where you live. Provincially here in Canada, how many of these surgeries and what is covered and what is not. So we'll go through that a little bit more at the 9 o'clock lecture. But these are possible surgeries, not all of which, in fact, most of which are not covered by OHIP. Very quickly, there are different ways of asking the questions with respect to gender, and you have to find a way that sort of works for you that's respectful, okay? But these are some of the options that you can ask people, but you have to keep in mind that you have to know why you're asking the questions and whether it's really important for the issue at hand, okay? So if, for example, someone is going into the emerge with an injured finger, okay? Dr. Mazzarella has a broken finger. So if someone is coming into the emerge for something like that, do you really need to know what their gender history is and whether they've had any genital surgeries? Does it matter? It doesn't matter, right? So, as you're sort of trying to figure out what questions would you feel comfortable asking somebody about their gender or transgender status, you have to think, why am I asking these questions and is it appropriate in this context? Some other possible questions that you might want to ask. And a lot of the questions are about people's self-identity and about if they do identify as transgender, their coming out process and how many people are they out to, what was people's reaction. It's more assessing that than somebody's legitimacy as a transgender individual, right? That's not really people's role to decide that. This is from Asking the Right Questions 2, which is a document that's available for free on the internet. It's produced by CMH. And this is some suggestions about how you can actually put this on your forms. Okay? So intake forms to whatever service usually have male, female as options for identifying someone's gender. You usually don't have any other options. So these are some other options that you can put on your forms. And it's a relatively easy thing to make your practice, your health center or wherever you're working, a more trans-positive environment. I don't know that I love this first question. It is from Asking the Right Questions too. At what age did you first identify as transgender or genderqueer or lesbian or gay or bi or whatever? So they do have that listed as a question. It's sort of like, well, at what age did you first identify as straight or as cisgender? Like it's sort of, to me, a silly question, but it is one of the questions in Asking the Right Questions too. the rest of them I do like. But again, you have to find what works for you and in the right context with the right. It's really about like, yeah, I know we exist as a group and I'm kind of okay with it, right? It's not enough, right? So to be LGBT sensitive is better. So it's to be more accepting, more knowledgeable, and more aware of LGBTQ people's existence. But really to be LGBT affirmative is the goal, okay? Certainly my goal when I do these kinds of talks is to make people want to be LGBT affirmative and to have some tools to be able to do that. So it's really more of not just an acceptance, but almost a celebration of diversity. That's the goal. So sometimes people talk about creating a positive space. So in terms of a positive space, there are various ways that one can do that. These are just some examples. I'm just going to speak briefly to the example of gender-inclusive washrooms. So a gender-inclusive washroom can be so liberating for transgender individuals, and even for some LGBT folks who may not present in typical gender-normative ways. Having a gender-inclusive washroom can really make your clinic, your healthcare environment, a more welcoming environment for LGBT folks in general. If you feel like you have had the education, you are LGBT affirmative, and your clinic is, and you are as a healthcare practitioner, consider listing yourself on the RHO, Rainbow Health Ontario web-based provider directory. Because people do look at that as clients, as potential patients. I've had some referrals, self-referrals that way through the RHO, and it does matter for some folks. They will look for your name. So very quickly, because I want to give Dr. Massarella her time too, 10 tips for working with transgender individuals. Okay? Welcoming people and letting them know about your service, so RHO is one way of doing that. Having a rainbow sticker is one way of doing that, but don't do the rainbow sticker unless you really feel like your practice is LGBT affirmative. Even if you are, if there are people who are working with you who are not, don't put the sticker up, because that's a false sense of security that people might get, thinking this is a safe environment, and yet it isn't. Okay. Treating transgender individuals as you would want to be treated. It's pretty simple, it's the golden rule, but people don't always do that. Okay. Remembering to always refer to transgender individuals with the name and pronoun that they wish to have. Okay? So this sounds simple, but it's not always in all environments. So even at St. Joe's, I have to keep reminding some of my colleagues that even when the patient's not in the room, if they're identifying a certain way with a certain pronoun, that's how we need to refer to that person, even when they're not in the room. If you're unsure about somebody's gender, identity, and how they wish to address, ask them. So sometimes people feel embarrassed to do that, but people would rather you ask in a nice way, like, how would you like me to refer to you as? What name would you like me to call you? What pronoun would you like me to use? No one's going to get offended by those kinds of questions if you ask it in an open way. If you have anti-discrimination policies, which most places do, healthcare environments do, if you don't already have gender identity and gender expression listed as one of the areas for protection, add it. Remember to keep the focus on the care of the individual and don't indulge in questions that are unnecessary. We talked about this a little bit before. Keep in mind that it's not always a training opportunity just because you have a transgender individual in your office. So don't bring over like 10 medical students to come see the trans person who's just coming to your office for something. Okay? It's not okay. All patients are training opportunities at teaching hospitals, teaching environments, but you have to keep in mind that you have to be respectful. It's inappropriate to ask about genital status unless it's appropriate to what the person is presenting with. Never disclose somebody's transgender status to anyone who does not explicitly need that information. Much like any other piece of the healthcare history that's not relevant. If it's not relevant, don't disclose it. become knowledgeable about transgender healthcare issues, so come to things like this, okay? And continue the conversations with your colleagues and networking. Lots of web resources. We're going to share these slides with you guys, so you can look through them later. My thank yous to a few individuals here, and I'm going to key up Dr. Messerales.